The recorder now.
Fab. I will try and pull up the slides. So I've been asked to talk about bronchiectasis today. So obviously, depending on the audience, this might be stuff you already know. So I do apologise if it's all familiar. Can you see the first slide there? Fantastic. The technology is working. Okay, good stuff. So I imagine some of you have some experience with bronchiectasis, maybe some of you don't. So just some background, really. So there was a definition of bronchiectasis being irreversible abnormal dilatation of one or more bronchi with chronic airway inflammation associated with chronic sputum production, recurrent chest infections, and airflow obstruction. Basically, we know bronchiectasis is a condition associated with lots of mucus or sputum and dilated airways. But does that seem familiar to everybody who's familiar with the condition? Getting nods in the background. So prevalence, data's a little bit old. 2012, around 210, 211,000 people in the UK diagnosed with bronchiectasis. Seems to affect women more than men. Seen different figures, but around 30-35% more in 2004 to 2012 in terms of diagnoses. And 60% of diagnoses were made in people aged over 70. Other prevalence data would suggest between 1 and 5 in 1,000 people in the UK have bronchiectasis, but again, it depends when you look at those numbers and where you take the figures from. An impact, again, this is old data now, but 2012 accounted for 0.3% of all deaths and 1.4% of lung disease deaths. Mortality rates basically are worse up north rather than down south, and the same with emergency admissions, which is perhaps not a surprise when we consider respiratory disease as a whole anyway. These figures were for non-cystic fibrosis bronchiectasis rather than CF as well. So a little bit of basic anatomy. I'm sure we're all very familiar with this. Breathing through the nose and the mouth. Better to breathe in through the nose. Warms the air with the blood supply, filters the air with hair, and then it passes into the trachea, and then down sort of a bifurcating pathway into smaller and smaller bronchus and bronchi until we get to the gas exchange area in the alveolar. Now the bronchi contain cells which secrete mucus, and also epithelial cells which are lined with cilia, which help in the mucociliary transport. We'll have a look at that in a bit more detail, but again, is that sort of a familiar cross-section to you all from an airway point of view? Okay, sputum. So the physios on the call, this is our area. What is it good for? So opening up to the group, just to make it a bit interactive, what is sputum there for? Well, why do we have sputum? What does it do? Any takers? Or is it too early in the morning? Okay, so we know
helps to clear the airways.
Thank you.
Bring all the bugs out.
Thank you, Carol. Yes, absolutely. So it acts as a layer to trap mucus. Mucus to trap bacteria, toxins, anything we're inhaling that shouldn't be there. And then the cilia act in a beating fashion to move the mucus upwards so that we can swallow it. Sorry, I know it's early in the morning. Just to get rid of this out of the lungs. We swallow about 30 mils of mucus daily, which is then eliminated by the gastrointestinal tract. The sputum itself is produced not at the alveolar level and not when we're getting up towards the vocal cords, but sort of in that mid area, we have this mucus layer that's moving up. So please forgive me for the hand-drawn cross-section of a bronchi there. I thought I'd get artistic and copy someone's YouTube video. The main issue with bronchiectasis is chronic inflation, dilatation or widening bronchioles, and some fibrosis that can underlie as well. But we need to understand the causes, and the primary problem is that basically people can't clear mucus, and there's lots of potential reasons for that. So we mentioned previously the normal structure. You have ciliated epithelial cells with cilia. Mucus is secreted, the cilia beats and moves the sputum up to be swallowed. What would you say is the most common cause for bronchiectasis? Anyone, any ideas?
Idiopathic, isn't it?
Yeah, fantastic. You read the slides. Yeah, idiopathic. Most of the time we don't know, but there are other causes that might be causes. There are other causes that we can identify. So thinking about things like cystic fibrosis or primary ciliary dyskinesia, probably familiar with cystic fibrosis. With cystic fibrosis, we have an issue with a gene that causes a problem in moving basically fluid into the mucus. The mucus becomes thicker, and although the cilia work, it's very difficult to move that mucus up. It's too thick and it sits there in the airway. With primary ciliary dyskinesia, quite common in a condition called cartilaginous syndrome, the cilia themselves are dysfunctional. So although the mucus may be normal, the cilia aren't able to beat properly, so the mucus then sits in the airway. If you have a chest x-ray and a patient has dextrocardia or situs inversus, the organs appear to be switched on the wrong side, that can be a good kind of clue in that there may be some underlying PCD. Also with PCD, the vast majority of males will be infertile, but both these cause the mucus to sit in the airway, making it harder to bring up, either being so thick or the transport system won't actually allow for it. Another possible cause would be obstruction. So the mucus itself is fine and the cilia are working, but there's something causing an obstruction. So we think of foreign bodies being inhaled, a tumour, certain lung conditions as well. If there's an obstruction, a narrowing, a blockage of the airway, the mucus itself can become trapped. So we know when we look at COPD patients, there's a crossover with bronchiectasis as well. On CT scans, you hear different figures, but a large proportion may have some underlying bronchiectasis as well. So just something to bear in mind with your COPD patients. Or could be caused by a chronic inflammatory process. So we heard of allergic bronchopulmonary aspergillosis, or ABPA. So something that's causing inflammation, chronic inflammation in the airways. What tends to happen is the body will produce more mucus as a defense mechanism, and that mucus then is hypersecreted in the airways. It can also be post-infected, so we know that people who've had a history of bacterial pneumonia or tuberculosis may possibly develop bronchiectasis as well. It looks like everyone's frozen. Am I still on?
Yeah.
That's fab. Just checking. Not technology this morning. Other causes to consider would be autoimmune conditions or connective tissue disease. Again, anything that might produce a systemic inflammatory response can potentially cause damage to the tissue, and then we end up with an increase in mucus production, again, as a protective response into that local area. So those are sort of the more common reasons for bronchiectasis that we might consider. So what's the primary issue with bronchiectasis? We know it's accumulated mucus. Apologies, early in the morning. Mucus traps microbes, and if that mucus isn't expectorated, isn't coughed up, it can cause infection or inflammation. That infection or inflammation locally can start to cause damage to the epithelial tissue, and we get an immune response. We get production of neutrophils, proteases, cytokines, and they respond by causing more inflammation, which can cause damage to this the basement membrane, damage to the elastic tissue of the bronchi, and then an overproduction in mucus producing cells. We end up with this cycle of inflammation and infection. So we have excess mucus either produced or trapped. That can cause damage to the bronchioles. We get microbial colonization, which produces more infection, which produces more inflation, which can lead to more cilia and epithelial damage, which results in reduced mucociliary clearance, and on it goes. So we can have a bronchi that, instead of looking like the normal bronchi on the left, looks a bit more like the bronchi on the right, with dilatation, widening, and damage to that airway, an increased mucus, possibly loss of cilia or ciliary function, all sort of building up to cause this this infective and inflammatory cycle. So what are the common features or symptoms that patients might have with bronchiectasis, or in your experience, what are the common features or signs and symptoms?
Lots of coughing.
Yeah, absolutely. Any more?
Lots of sputum.
Yeah, cough, sputum. I mean, it will vary depending on the patient, but cough, breathlessness, sputum, hemoptysis as well can occur. I think obviously if you get damage to that epithelial wall and the basement membrane, you've got blood vessels in close proximity, and you can get hemoptysis through damage through there as well. Other things to look out for: weight loss, colonization with certain microbes. Pseudomonas aeruginosa is quite common if we have sputum microbiology. People who present quite young. Someone who's got a chest complaint but an absence of smoking. Now, obviously you can smoke and have bronchiectasis, but someone who's not a smoker but has been diagnosed as COPD, might want to dig a little bit further. So if we're thinking of suspicion of bronchiectasis, we'd look at patients who maybe have persistent mucus production, especially purulent or mucopurulent, so grotty phlegm, basically. They've been coughing, but they've had one of the triggers we talked about previously. History of rheumatoid arthritis with a chronic cough or recurrent chest infections, a COPD frequently exacerbated with positive sputum microbiology, COPD patients diagnosed who don't smoke, or people with connective tissue type diseases as well. So all patients to have that suspicion in mind. So thinking about sort of a primary care or community level, what kind of investigations might you request for a patient? This is all covered in the thorax BTS guidelines, by the way, if you want to have a dig down into much more detail. What sort of things can you request just to try and help sort of guide your assessment?
Chest X-ray, CT.
Yeah.
Yeah.
I think certainly CT, certainly in sort of secondary care, definitely. So I think primary care, you might want to think about sputum cultures to start with. You send a culture, you don't get a result straight away, but it goes to the laboratory, and they can assess if there's anything growing, and if there is, what it's sensitive to. Chest X-rays also help to rule out other pathology as well. If you've got someone presenting with respiratory symptoms, you want to make sure that we're not missing anything else. So chest X-ray is a good place to start as a baseline. With spirometry, obviously, you're sort of thinking more along your COPD and asthma or restrictive conditions with this, but it can be helpful just to establish any element of airway obstruction, but also to look to see if there is underlying asthma as well. Is there any airway reversibility if you do reversibility testing? Baseline OBS, obviously we're doing all that just to make sure we know where a patient is to start with. Baseline bloods and any other investigations basically is guided by your clinical findings. Fairly obvious, really. And then obviously in secondary care, there are a few more options potentially. So we mentioned CT scans. The other things that might be performed, things like sweat tests or gene testing for cystic fibrosis, especially for children or younger adults or patients with other symptoms beyond the respiratory that might point to cystic fibrosis. Might want to do screening for antibody deficiency, so immunoglobulins, and there's also specific tests for aspergillus. As we mentioned, ABPA is a potential cause for bronchiectasis or a trigger. And then tests for primary ciliary dyskinesia. So nasal nitric oxide, I think, is used as well, just to try and help confirm that. But obviously, as we mentioned before, if you have a patient with dextrocardia or situs inversus, it might point you in that direction as well. The reason for identifying a cause is that some of these are treatable. So rheumatoid arthritis, someone can be referred to a rheumatologist, certain connective tissue diseases as well. So if there's a treatable cause, we want to make sure we treat that. Obviously, for some causes that there is no treatment, but it's useful to rule these out. So thinking of a CT, what would we look at a CT? What would show us that somebody has bronchiectasis? Any ideas? Okay. Not going to go through that. It's just different types of bronchiectasis that might appear on the CT scan. But we're looking for something known as a signet ring sign. I don't know if anyone's heard of that before. It's one of the more common signs on a CT. Basically, you have normally a bronchus to artery ratio of 1 or less than 1, demonstrated by the red and yellow circles there. If it's greater than 1, it can indicate airway dilatation, commonly known as a signet ring sign.
Okay.
So
All
if
right.
you hello there. So if you look here, I've got my pointer on actually. If we can see there, we've got a airway that's dilated, and then the blood vessel just to the side there apparently looks like a signet ring. Again, similar here, it's a little bit harder to see, and then here as well. So you get that larger airway with the associated blood vessel looking much smaller as well. Can also get what known as trantract signs, which is where we don't get tapering of the side-on slice of the airway as well. You might also find you get bronchial wall thickening, so the actual bronchial walls appear thicker on the scan, and mucus impaction appearing on the scan as well. It's important at this stage as well to mention traction bronchiectasis. I don't know if that's something that you've heard of before or familiar with, but patients with fibrotic lung disease, because the fibrosis tends to pull the interstitial tissue, you can also get dilatation of the airways, but it tends to be asymptomatic and isn't treated in the same bracket. So if a CT scan report mentions bronchiectasis, it's important to determine, is this bronchiectasis in a traditional sense, or is it traction bronchiectasis? Because the treatment and management may be slightly different there. Okay. So, I don't know if we can see this, but there are guidelines for managing deteriorating patients on the British Thoracic Society. So basically, for any patient with bronchiectasis, where's Julie? If we have a significant deterioration of symptoms and an unexpected increased frequency of exacerbations, you might want to reassess the patient. So the usual assessment, possibly baseline gases, CT chest to check for any changes. And then considering underlying causes, the things we've discussed already, basically. If you do want to have a look at the guidelines, there's a QR code there to scan with your phones just to bring them up as well. And then considering other comorbidities, so obviously assessing the patient thoroughly. And then we look at optimization. So airway clearance, obviously the physios in the room will be familiar with this. And then check they're compliant with this, make sure they're reviewed by a respiratory physio. Pulmonary rehab's obviously an option. You can read through all these as you wish, but basically it's going through the process to make sure the patient is optimized. As a patient deteriorates, though, there are further options that may be considered, such as inhaled or long-term antibiotics, and then sort of towards the end stage, long-term oxygen surgery and transplants. All things to consider, but the guidelines go into this in much more detail. Obviously, from a virtual ward point of view, we're seeing people for a couple of weeks, but it is useful to be aware of these, especially for onward referral if a patient has deteriorated. I think this shows it in a little bit in a simpler form. So step one, treat the underlying causes. Make sure the patients have chest physio, have their annual flu vaccinations, gets prompt treatment with antibiotics for exacerbations. Obviously, going back to the pathophysiology, these patients are more prone to infections because that mucus traps microbes and keeps them locally. And making sure a patient has a self-management plan or access to a community respiratory team for support. If a patient is exacerbating regularly, making sure they have their physio reassessment, considering mucolytics, and again, if they continue to exacerbate, considering other treatment choices. So again, there's a stepwise approach you can follow to managing those patients, which ends up with regular intravenous antibiotics, but we don't see those very often. Has anyone come across azithromycin for bronchiectasis patients, or is using azithromycin?
Yeah, we have quite a lot of patients that are on azithromycin as preventative treatment.
Yeah, obviously with azithromycin, probably aware it's important to make sure before a patient goes on, they have liver function tests and a baseline ECG just to check the QTc interval. And ideally, that should be repeated at regular intervals as well. Patients can develop tinnitus with azithromycin, so they need to be aware if they develop that. It may be a reason to stop taking the azithromycin. If it develops and they stop taking it, can reverse, but if they continue taking it, it may become a fixed condition. What about nebulized antibiotics? Anyone familiar or come across those at all?
We do columicin trials as well on our team.
Ah, fantastic. Yeah. So yeah, inhaled or nebulized antibiotic, so it can be delivered straight to the airway for everybody who's unfamiliar. There are some challenges with that. First of all, you need to do a challenge, as mentioned. So with these medications, there is a risk of a bronchoconstriction or a reaction. So we like to do a challenge, get some baseline spirometry, get the patient to take the medication, and then repeat that spirometry to make sure they don't bronchoconstrict by a significant amount, just from a safety perspective. There are also issues around the delivery of those medications that require special nebulizer sets that either exhaust or are filtered so that other people in close proximity aren't exposed to antibiotic when they don't need to. So a few more complications, but there's certainly options available for patients as well. Okay, physiotherapy. So for the non-physiotherapists in the room, is anyone aware of any chest physiotherapy techniques or procedures that might be advised or carried out with patients?
Yeah, active cycle breathing technique, ICBT.
Fantastic. Yep, absolutely. So first one, active cycle of breathing technique. There's also a technique called autogenic drainage, which is about altering the volumes in the way we breathe. But our sort of bread and butter tends to be active cycle of breathing technique. So breathing exercises that we ask the patients to perform to try and help clear their chest. So usually there's an element of relaxed breathing control, followed by some lower thoracic expansion exercises to try and expand the chest, get air down into the lungs, and followed by what's known as the forced expiration technique, or huffing and puffing to most of our patients, usually where we ask a patient to do a slow or a high volume or there and thereabouts, which I'm sure if you've seen any chest physio, you'll have seen us doing with patients. And that is a cycle, so patients will do that for a period of 5, 10, 15 minutes to try and help optimize the mucus clearance and facilitate that. Quite a good technique to teach someone, because once someone knows how to do it, they don't need a physio there, so it's cheaper than some of the techniques. Any other techniques that you're aware of?
Yeah. Bubble pep.
Bubble pep, yeah. So bubble pep was always the sort of Blue Peter approach we used when we can get hands on other bits and pieces, but it works well if you pick the right patient. So the idea is you get a container of water, has to be quite a tall one, fill it with a 10 centimetre depth of water and obtain a large straw and get the patient to exhale through that straw, and we get positive expiratory pressure to try and help facilitate airway clearance. Used to work well with the McDonald's drinking straws, but now they're paper, they're rubbish, and with the plastic straw ban it's a little bit more difficult, but it's certainly a possible technique. Any others? Okay. So there's manual techniques, which I think in some people's heads look like this, but actually looks more like this. So in the good old days or the bad old days, you might have had a physio ask a patient to lie on their side and percuss their chest. Quite labour intensive, so you need a physio or someone who's been trained to do this for every patient. Lots of patients like this, especially patients who were treated maybe sort of 30, 40 years ago, and feel like they're getting a treatment rather than doing something to themselves. Gone out of fashion a bit, partly because of the requirement for staffing, but also a lot of our patients now are maybe osteopenic or osteoporotic, or have taken regular courses of steroids, and whacking someone on the back with those kind of risk factors may not be the safest approach, but it's still a possible technique and used with children as well. Postural drainage. Another technique to add in, often find this works alongside these other techniques, but basically if you know the anatomy of the lungs, you can ask someone to tip themselves into various positions to then use gravity to assist that drainage, just to try and help. And postural drainage on its own probably won't be that effective, but if you combine it with another technique, you're getting a little bit of a boost as well. And then OPEP, which similar to the bubble pep, but basically there are devices that can be obtained on prescription, such as the acapella in the top left, the flutter in the top right, the air beaker in the bottom left, and I'm not sure what it is, but a similar kind of device. And basically it's a plastic device that a patient will exhale through. There's a narrowed aperture which creates the PEP, but also either a weighted lever or, in the case of the flutter, a metal ball bearing that vibrates through exhalation, and that causes the oscillation. So it's, I suppose, sort of a bit like percussion, but inside the airways. Again, works quite well with the right patient. One important thing is to make sure that patients are cleaning their devices regularly. Obviously, with that infection risk, we've seen some that are crawling basically when patients don't. So as with nebulizers and everything else, do make sure your patient's clearing their devices just for their own microbial safety. And then, I've never really seen this, but I've not worked on CF units, but essentially a vest or a jacket that's attached to an air compressor, I believe, but it performs a form of percussion that it can be worn basically. But again, I've no experience with those devices myself. And then finally, exercise. It sounds simple. Certainly with children, this can be a good way to help clear the chest. If you get someone who is chesty to run around, besides being breathless, chances are they will bring up more phlegm as they're expanding the chest more and moving those airways. So something to consider depending on your patient. Also, exercise in general. We have pulmonary rehab, which was obviously traditionally set up for COPD patients, but we know benefits most respiratory patients if they're functionally limited by breathlessness. Then exercise and pulmonary rehab are important adjuncts to add into the treatment. Chest clearance frequency should be tailored to the patient. We generally recommend doing sort of bursts of 5, 10, 15 minutes, but probably no more than that at a time. Depends on the patient. It can be very tiring going through these techniques, very tiring. So often patients will need a break and then to come back to it later. The other thing is about optimizing patients. So if patients are prescribed short-acting bronchodilators, it may be beneficial to get them to implement those 10 or 15 minutes before they do their chest physio. So you're optimizing that bronchodilation. And then if they have other inhalers, so inhaled steroids or other medications, especially if they've also got COPD or asthma, if they take those after their chest clearance, well, you've potentially removed some of the barriers to that spray or powder being absorbed. So just some points to consider. Okay, mucolytics. Anyone familiar with any mucolytics? I'm sure you are, but now's your chance to shout them out. What things do we advise patients to use or ask or ask to be prescribed for our patients?
Carbocystine, Naxis.
Yeah, so carbocystine, probably one of the more familiar one. Big torpedo capsules, usually start with 2-3 times a day, dropping down to 2 twice a day, depending on the patient and the dose. I think studies have shown that carbocystine reduces the production of glycoprotein, basically, so it can reduce the hypersecretion, either taking it prophylactically or after exposure. So it reduces the viscosity of the mucus, basically. Naxis, a bit more of a recent one for us. Benefits are it tends to be that it's the effervescent version. It's once a day, dissolving half a glass of water. So from a medication burden, it's easier. Has anyone else had any issues obtaining Naxis recently? We've sort of hit a wall where pharmacies weren't able to obtain it for a period, but I'm not sure if that's stopped now or if that affected other areas.
Not had any issues. Most of our patients are on carbocystines.
Okay. Yeah, that may have just been our luck then. Has anyone heard of saline nebs?
Yeah, and they hypertonic saline.
Yeah, absolutely. So if your patient's taking the nebulizer like that, you need to reassess them. Should be using something like those. But yeah, there's different flavors of saline nebs. Previously quite common was the 0.9% saline nebs. Personally, I'm not sure how effective they will be. The saline is at 0.9%. It's the same salinity as your normal body tissue. The whole point of saline nebs is to create an osmotic gradient. We have an area of high saline in the airway, which draws out water into the airway and then into the mucus. So 3%, 7% saline are the ones that are most commonly used. We tend to do a challenge or a test dose with these patients as well first, again, baseline spirometry, and then measuring the the response after they've had the saline, just to make sure that it's safe for them to take. But it can work quite well and can be quite effective. And then not forgetting, perhaps most importantly, just basic hydration. It's often overlooked. I've seen some studies to say that a moderate amount of dehydration may not make much of a difference to mucus viscosity, but for some of our patients, dehydration is a big risk, and it makes sense to make sure they're hydrated. Hydrated systemically means the mucus is more likely to be well hydrated as well. So encouraging patients to monitor their oral fluids as well. And then vaccinations, as with all these guidelines, this is sort of pre-COVID advice, but patients should be offered flu and pneumococcal vaccinations. Again, these patients are more at risk of picking up infections, having infections that last longer. So we should be encouraging this in all our patient groups, and obviously COVID vaccines as well. And then finally, looking through at sort of antibiotic therapy, obviously we have the pan-Mersey guidelines on the right there. Quite useful if you are treating someone without any microbiology to start with. So usually first choice is doxy or amoxicillin, with alternatives being co-amoxiclav. We tend to use 14 days worth of treatment, which matches the BTS guidelines on the left-hand side there. The important thing though with bronchiectasis patients is to try and get sputum microbiology. Ideally at the start of an exacerbation. Now, it can take 5 days or so to get that result back, although if you're concerned, you can always ring your microbiologist and ask them if they've got a preliminary report, especially if the patient's not responding to treatment. But it's important to see if a patient is growing a particular bacterium as to what antibiotic might be suitable for them. So BTS guidelines have quite a good guide there on the left-hand side, but also your local microbiologist will guide you. So if you're not sure, or if there's any ambiguity, phone microbiology, speak to a microbiologist, and they will guide you into an appropriate choice for your patient, especially where there's issues over IV access or oral access as well. So from our patient's point of view, it's important to make sure that we diagnose them properly. If we suspect bronchiectasis, we do baseline tests, referring to secondary care, CT confirmation, and then treat any underlying causes if we can identify them. Patients themselves should be optimized. They should, if they have a diagnosis of bronchiectasis, should be seen by a chest physiotherapist and advised on basic chest clearance techniques, should be offered flu and COVID pneumococcal vaccination, offered pulmonary rehab if they have any functional limitations with breathlessness. They should have a management plan in place so that if they develop any exacerbations or chest infections, they have prompt treatment. And based on recent guidelines, should be offered an annual review as well, where all these things are checked. So baseline microbiology, baseline OBS, and if they deteriorate, there's a pathway to follow to try and escalate their treatment, try and really keep these patients stable. It's a bit of a whistle-stop tour through all those slides, mainly because I wasn't sure exactly what audience I was pitching to in terms of everyone's experience. But does anyone have any questions or anything to ask? Which is a question, I suppose.
Why my cameras?
Oh.
Doesn't seem to be no hands.
I
I think there may be something in the chat. Oh no, it's just someone's
all my screens are frozen for everybody else, so I wasn't sure if I had an audience there at one point, which is why I was asking for the questions and the feedback. So it's maybe a little bit shorter than the hour we had in there, but it's a Tuesday morning, so.
Yeah, don't worry, David. What we are going to be doing is some Q&A session. So from the feedback that we get, if there's any questions that come up from the presentation, obviously other staff will have access to it because we've recorded it as well. So if anything does come up, we can set up another half-an-hour session if that's okay with you for Q&As.
Absolutely fine.
Fab.
I mean, the thing is,
Lovely.
obviously, from a virtual ward point of view, we're not diagnosing, although you might have a patient where you suspect that and it might prompt a referral on to secondary care for diagnostic tests. So in those patients where you suspect, is this an underlying bronchiectasis as well, it's worth having these things in mind so that you can refer on. but also for those bronchiectasis patients that we have, making sure their treatments are optimized. Do they have access to a physio while they're exacerbating, and all of the things therein.
Lovely, thank you. So if there's no questions, I think we can end it there. Let
Thank
me
you very
just
much,
stop
everybody.
recording. Okay, stop recording.